nutrition plays a huge role, especially the composition of our food, of our macronutrients in neuropsychiatric illness. I think one component is certainly neuroinflammation, which we have very poor tools to quantify at this moment, I must admit. Say if I can do talk therapy with this person and then monitor their neural circuit firing pattern all the time, and you try to forcefully correct it in a way that's going to activate aberrant pathways, I do think that can make someone psychotic. I think if your overall mood stabilized enough, which I do feel carnivore diet contributes greatly in my own case, you tend to be more cognitively agile and stable in doing higher level work.
Okay, good morning, everybody. Happy Monday on this July 4th holiday weekend type thing. Today we have, once again, Hui Yang is here. I will just assume you can hear me. How are you today?
I'm good. I'm doing really well. Thank you, Dr. Baker, for sparing me a slot to conduct the interview today. I really appreciate all the audience being here.
Thank you once again for doing this. I think we spoke, it's been maybe 2 years or so, I think, the last time I talked to you. And so you were in the midst of your MD PhD process and doing some neat stuff. And so I guess it's a bit of an update. So tell us a little bit about what's going on with you lately.
Sure, yeah. So I finished the PhD portion of my dual degree training. So I actually defended in October last year. And then I went into finishing the last 18 months of the dual degree training, which consists of me going through the clerkship training through 5 subspecialties. The order I did them were pediatrics, OBGYN, then I did internal medicine, then I did neurology and psychiatry, and then last I finished with surgery. So now I'm at a studying phase to pass a series of board certification exams, as you know very well, like those STEP exams. And then actually I'm scheduled to do 1 month of visiting elective at Johns Hopkins University, their medical school, one of the good training places, especially for the subspecialty I want to go into. It was an honor for them to offer me the visiting acting intern opportunity. And then I came back to my home institute to do 2 more acting interns, which basically you function as a first year resident. That's why we call acting intern, to prepare you for residency. And at the same time, you go through the whole residency application, interview process, and hopefully move on to your next stage of training starting in sometime June next year.
Okay. Congratulations on that. I know it's, like I said, I know there's a lot of work ahead of you having gone through that many years ago. You said you chose a specialty. So what specialty are you going to go into?
I'm going to go into research track neuropsychiatry, especially with the focus on the nutritional and periphery. My research is in CNS control of acute hunger satiety and long-term energy homeostasis and body weight management. So I do intend to stay in this field and certainly try to make the field more receptive to the idea that nutrition plays a huge role, especially the composition of our food, of our macronutrients play a significant role in neuropsychiatric illness.
Yeah, and thank you for doing that. And I know you're probably familiar with guys like Chris Palmer, Georgia Eade, and some of the other ones that are also certainly down that track. I guess we should just mention your history, because you had suffered from severe anorexia at one point, and you went on to figure that out basically with, a carnivorous type of diet. And there was recently a case series published in the Journal of Insulin Resistance. I guess Nick Norwich was the primary author in that, and he took, I think, several people that had were suffering similarly to you with pretty severe anorexia, and again, using carnivore to do that. And I guess I should ask you, because there's a lot of talk about satiety per calorie, that diet doctor folks have shifted that is to be one of their models for solving the obesity crisis, if you will. How do we know how food does impact our satiety? Because people say you should just cut calories, but then you're like, but I'm hungry. That's hard to do. So how does that work? What's your overview understanding of how different foods, different macronutrients, different nutrients impact our desire to eat more or less?
Yeah, we can certainly go into that. On the other hand, I just want to mention, so actually I reached out to the Revero community meeting organizer, mainly because especially after I finished the surgery clerkship, I feel compelled to disseminate certain information to our audience, especially our pre and post-op nutritional management for very common and actually quite invasive procedure. For example, Dr. Baker, you probably recall during your training, you may not have done it, or it may not be your forte because it's a solid internal organ procedure, but you might have heard of it, this famous Whipple procedure. Whenever you get a pathology at the head of the pancreas, you have to take off a whole chunk of associated organs. That's just our anatomy. And we actually see quite a bit of that procedure performed in our academic teaching hospital, which is common because it is a challenging and very big procedure. And it has become surprisingly common, not only because of the invasive frank pancreatic cancer, but also surprisingly, neuroendocrine tumors at the head of the pancreas. We're seeing it more and more. And I have never seen a good outcome from patients from that procedure. And the way we manage their nutrition after the procedure is absolutely disheartening. So I actually fought in the hospital with the dietitian, with the team that formulated a patient's TPN, the total parenteral nutrition. I fought with them, and it was just, I want to at least transmit that information to our audience. I do feel as a physician, I don't want to take a paternalistic role towards our patient. I want them to feel they're adequately equipped to argue back with me. And that's when I feel I did a good job as a doctor. But circle back to your question. So subjective feeling, you can do as much as kind of survey type of research to say what's the level of satiety after you eat meat versus carbs. But the definitive way I can tell you it signals satiety to the brain is that I know a neural pathway or a group neurons in a specific region of the brain, for example, the POMC neurons in the hypothalamus. I know if they are adequately activated to pass certain threshold, you can influence the behavior. So I see the neural pathway, the innate neuronal activity, and I can see a behavioral output change. So I know that the animal stopped eating, even if it's been starved for 3 days, I activate the POMC neuron. So the way I can recapitulate that by feeding animal different macronutrients is that, say, I starve the animal for 3 days. So if anything, it makes it more difficult to elicit satiety, right? If you can elicit satiety in a starved animal, that's pretty potent compared to you elicit satiety in an already fed animal. So I make them into a starved state. If I give them different macronutrients, I can see the neuron. I image the neuron real time or image the neuronal pathway either by 2-photon calcium imaging or by direct electrodes, or now we can massively parallel electrodes, implant those very fine probes that's actually made exclusively in Belgium in the clean room. Like Belgium, the lab in Belgium, they actually make all the highest tech chips during the chip shortage. Why there's so much talk about the kind of the Belgian, the Taiwan, all those kind of communication was because certain like key components of that technique can only be made at Belgian. That company is also the one who makes those dense electrodes. So either by imaging or by direct recording, I can record a neuronal pathway activation, and I can see a behavioral change. The animal stopped eating, although it only took 2 bites after being starved for 3 days. So I know that's even though it's a very artificial experimental setting, I know for sure it's the satiety pathway is activated.
Okay.
So I think, yeah, that's what PhD can do, a neuroscience PhD can do compared to someone who is just washing, dosing off, kind of distributing the questionnaire. I'm not saying those studies are not meaningful, they are, but the ways we rigorous neuroscience do it is by this way.
Okay, so you put an animal in a state of starvation by not feeding for a couple of days. You can monitor what's going on in the hypothalamus, looking at neural pathways. And then how do you, so experimentally with animals, and remember animals are not humans, but there's certainly some similarities there. But what are you seeing as far as what shuts down appetite in a starving animal? What sort of macronutrient blend, I suppose, does that?
So there are actually different components of the feeding circuit. So there is homeostatic feeding circuit where you are legitimately hungry. If I give you carrots, you're going to go eat it. The other is a hedonic feeding pathway where you would bypass a celery stalk or carrots, but a donut looks really good to you. So that's hedonic feeding. And we can develop a aberrant hedonic feeding pathway. That's why certain people can feel a hedonic sensation by overeating cheese. So it's not, you say, if you're always pairing eating meat with win ton of money from casino, you can develop a hedonic feeding pathway by eating meat because you've conditioned it to be paired with something truly rewarding to you, earning money from a casino. So I think we need to be cognizant regarding when we're saying, are we activating the satiety component of the homeostatic feeding pathway versus we are activating the satiety or the stop signal in the hedonic reward pathway. So I would say overall, in general, actually, I think I mentioned it. It was very early study. I have a lot of reverence for the earlier, very rigorously done, but you look at their experimental technology, it's not fancy. It's very kind of rudimental, but it's rigorously done. I have a lot of reverence for researchers done back in 1980s. I think I mentioned in our last interview, one type of fats that's exclusively from ruminant meat. So it has to be ruminant. Chicken doesn't do it. Salmon doesn't do it. Lamb and beef certainly do it. It's a key component in one of the key satiety signals through the homeostatic pathway from the upper GI tract through the vagus nerve into the brain. They did it so vigorously that they made fat of the same chain length and the same bond structure, but one bond kink was different. So that's the single structure difference they changed. They also made fats that have the same mouthfeel. So they bind exactly to the receptor in your mouth because they want to rule out what we call a gustatory effect, because the receptors in your tongue also signal the brain telling you what type of macronutrients or how rewarding whatever you're eating is. So they rule that out by making fat that also activates the receptor on the tongue, but cannot signal to the brain. They even made a third fat that the same structure, the same binding property, but cannot be digested. So the calorie cannot be reabsorbed. And they ruled all that out to make sure it is the specific fat in the ruminant meat. So that's at least the one thing we know to signal to the brain about innate satiety.
Okay, so within ruminant meat, we have several different carbon chain length fats: palmitic, oleic, stearic.
I thought it was palmitic derived. If I remember it correctly, I have to go back to the study if I need to be absolutely sure. It's 18 chain lengths.
Okay, and you mentioned that was shutting down the hedonic pathway, I think.
No, that's shutting down the homeostatic, pathway. So you are not artificially seeking reward anywhere. You are just legitimately hungry. Now, what can fulfill you?
Okay, so ruminant meat has some unique fats in there that tend to be effective at shutting down or stimulating these neural pathways to signal a satiety.
Yeah. That's why personally I ate less. I almost never eat chicken or pork.
Yeah.
It's just me personally.
Yeah, me as well. It doesn't seem to be as appealing for one, and it just maybe doesn't seem as satisfying. So obviously with that sort of data in mind, the sort of pharmaceutical industry, how do we stimulate this neural pathway to shut this down? And now we have these GLP-1 receptor agonists that are very popular now. And obviously we know that the incretin hormones also have a role in satiety, as does things like CCK and some of these other hormones. Yeah. So what's going on with these hormonal influences? Because obviously there's a neuroendocrine portion of that where hormones affect neurons and neurons affect hormones. How does that all mix together to lead to this stuff?
You mentioned CK. It actually ties back into the Whipple procedure I was mentioning earlier. So if I may, I actually want to show this video from Hopkins website, which shows you what a Whipple procedure is. And it actually ties nicely into the idea of CCK. Would you like me to show, or would you like me to verbally just describe?
No, I mean, I think it helped visually. I remember being part of Whipple procedures long time ago, and it's quite an extensive procedure you recommend and typically done for pancreatic cancers. But sure, you can show it. It'll help people understand this. So that's just for people, that's a cross-sectional area through the abdomen, and the pancreas is that yellowish thing sitting there.
It's an organ that resides deep in the abdomen. It rests against the backbone in front of two major blood vessels called the aorta and the inferior vena cava. It is also covered by the stomach and the liver. The pancreas is divided into three anatomical portions: the head, body, and tail. The head of the pancreas is surrounded by the duodenum, the part of the intestine that connects the stomach to the small bowel. The tail of the pancreas resides in the hilum of the spleen. The pancreas has two very important functions. Most of the gland is involved in producing the digestive enzymes that are collected in the main pancreatic duct and then emptied into the duodenum. These enzymes are involved in the digestion of fats, sugars, and proteins. There are also small microscopic groups of cells dispersed throughout the pancreas called the islets of Langerhans. These small groups of cells produce a variety of hormones, including insulin, that are released directly into the blood and help regulate a variety of different functions, the most important of which is keeping the blood sugar or glucose in a normal range. Glucose is the main source of energy for the body. A variety of benign and malignant tumors can arise in the pancreas, often in the head of the gland. Tumors in this area present a particular problem because the head of the pancreas is at an important crossroads where the pancreatic duct empties its digestive enzymes into the duodenum, and the bile duct delivers bile from the liver and gallbladder. If a malignant tumor, such as a pancreatic cancer, arises in the head of the pancreas, it will often block both the pancreatic duct and bile duct, resulting in the patient turning yellow or becoming jaundiced. When the bile duct is obstructed by a tumor, bilirubin, a yellow substance produced in the liver, is no longer able to empty into the duodenum and be excreted, and backs up in the blood, and the patient turns yellow. This is often first noticed in the whites of the patient's eyes. Yellow jaundice is often the first clue that the patient has a pancreatic tumor. Weight loss and abdominal pain may also be symptoms of a pancreatic tumor. When these symptoms are present, the physician will order a CAT scan to look for a tumor or other important signs, such as a dilated bile duct in the liver or a dilated pancreatic duct, both of which can be caused by tumor obstructing the ducts. If cancer is diagnosed, the physician will use the CAT scan and possibly a variety of other tests to stage the cancer and determine whether the tumor has spread beyond the pancreas. If it has not, the cancer is considered resectable, and the patient is a candidate for an operation called the Whipple operation or a pancreaticoduodenectomy. The Whipple procedure or pancreaticoduodenectomy is a major operation that often takes between 5 and 6 hours. The patient is admitted to the hospital, prepared for surgery, and then put to sleep with general anesthesia. After the patient's abdomen is prepped with an antiseptic and draped appropriately, generally the operation is performed through a midline incision. Under certain circumstances, the operation can also now be done laparoscopically through 4 or 5 small incisions. However, most operations are still done through an open incision. Once the incision is made, the surgeon carefully explores the abdomen to confirm that the tumor has not spread beyond the pancreas and its surrounding area, and therefore can still be surgically removed. Because the head of the pancreas is located so deep within the abdomen, many structures have to be divided before the tumor can be removed. The gallbladder is mobilized and the bile duct leading to the duodenum is divided. Next, the duodenum is divided to preserve the entire stomach as well as the pylorus valve and the first portion of the duodenum. This is referred to a pylorus preserving Whipple procedure. In some cases, the surgeon may perform a classic Whipple procedure where a portion of the stomach is also removed. The neck of the pancreas is divided, being certain that no tumor is left behind in the neck or body of the gland. One of the most important steps in this operation involves removing the pancreas and tumor from 2 important vessels that supply blood to the intestines and return it to the liver. These are called the superior mesenteric artery and the superior mesenteric and portal veins. Occasionally, if these structures are involved with tumor, portions of these important veins are also removed. This dissection is quite complicated and prolongs the operation. The proximal small bowel, called the jejunum, is divided, allowing the entire specimen to be mobilized and removed from the body. Once the specimen, consisting of the pancreas containing the tumor and the surrounding tissues, is removed, the reconstruction is then carried out in a stepwise fashion. Generally, the remaining pancreas is reconnected or anastomosed to the proximal small bowel in an end-to-side fashion. Next, several inches beyond the first anastomosis, the bile duct is reconnected to the jejunum. Finally, downstream from the bile duct anastomosis, either the duodenum or stomach is reattached to the jejunum, depending upon whether a pylorus preserving or a classic Whipple has been performed. So, in summary, a Whipple operation or pancreaticoduodenectomy removes a portion of the pancreas containing the tumor, the gallbladder and distal bile duct, and most of the duodenum, along with a section of small bowel or jejunum. The reconstruction includes anastomosing or reattaching the pancreas, the bile duct, and duodenum or stomach to the small bowel or jejunum. Patients undergoing this extensive operation are often placed in an intensive care unit for observation for the first 24 hours after surgery. The next day following surgery, the patient is gotten out of bed, often ambulated, and the nasogastric tube that is placed through the nose down into the stomach during the operation is removed. Many patients will start taking sips of water during the first postoperative day and usually will be discharged from the intensive care unit and go to a floor.
So we can stop here and I'll stop sharing for now. So if you think about it, it's actually probably the lay audience would not ask this question right away, but there's nothing wrong with the gallbladder in this patient. Why is gallbladder removed?
I think the proximity to the tumor is a concern. And you've got, is it spread to the gallbladder? Is there a communication between the tumor and the common bile duct? Or those types of things are probably why that's removed.
That's one minor reason for sure. But actually the major reason is that because of the duodenum must be removed, duodenum is the only portion in the GI tract where we make CCK. And the gallbladder contraction relies on CCK. So if you remove the duodenum and you leave the gallbladder in, you will have biostasis. Basically, the gallbladder never contracts. You're going to have a dead pond of bile just sitting there. So we basically take away actually a lot of the honestly healthy tissue in this procedure just because the interconnectedness of the signaling molecule that ensure the proper mobility and peristalsis in the GI tract. And Shawn, you probably know this. If someone can routinely do a Whipple within 6 hours, I applaud them. Usually when I was on surgical oncology service, if you can finish a Whipple within 8 hours, you are lucky. And then I give the example of I had a patient who he is a very active and community organizer actually in the Bronx area. He was all up and down, like just jumping and just a happy person, very active person before the procedure. Come in, got the procedure done, went home. 1 week post-op coming in. We look at the back, basically he has a drainage back there. It doesn't look right. It's draining something that look milky. We think he had a chyle leak, meaning leaking from not blood, not any digestive juice, leaking from the lymphatic system. And we don't know why. And he looks very weak. So we had to readmit him into the hospital. And the Whipple procedure, for some reason, it shocks the pancreas in a way that even if you're not diabetic before, your blood glucose just went. In the hospital nowadays, we do this permissive hyperglycemia because of I think it was actually the famous trial's name has something to do with sugar too. It shows that the patient outcome in the intensive care unit is slightly better if you let them their blood glucose run as long as it's below 180. It's fine. You don't have to go below 100 or below 120. Fine, we take that. And then, but for those patients, their glucose is routinely run in the 400s to 500s in the hospital. And then they're getting TPN. So we're controlling how much dextrose goes into their TPN bag. And then we're chasing it with insulin all the time. And somehow you just can't get it under control. This poses actually a just practically discharging barrier, because then even if this patient is all fine in every other aspect, you can't discharge them to a rehab center because the rehab center can't routinely manage someone whose blood sugar is spiking up to 500 all the time. They just refuse to take the risk. So we retain those patients in the hospital and they get complication. They bleed. Like this patient at 8:35 p.m. one night, he was bleeding. He was rushed back into the OR. SMA was bleeding. So this is also interesting in the New York area. If you're the sole chief surgeon, you identified a major arterial bleeds, by law, your hand cannot be off the bleeding artery. If you identified it, you have to basically hold it to ensure hemostasis and then call someone in. It's like a law. If you take your hand off, this person bleed to death, like you can be sued, basically. So this patient didn't have a good outcome. And then in the management of this patient, I begged nutritionists. I said, look, this patient's doing nothing in the hospital. What if we take dextrose entirely out of his TPN bag so we don't give him any glucose? And then the nutritionist was like, yeah, theoretically it could work. He's still a live person. The brain needs 120 grams of glucose anyway. I was like, this person's not using his brain when he's lying here all day doing nothing. And that 120 gram of glucose, he can make it from his liver. just by gluconeogenesis. Can we give it a try? What if we just don't give him any glucose into the TPM bag? Because his TPM bag is already customized, made, theoretically we can do it, but then the nutritionist still does not feel comfortable. And I have to honestly say, she is an intelligent person and she's very open to discussion. She's not like the dogmatic person. So I just took a more relaxed approach. I almost exonerated her clinical role. I said, let's just imagine this context. You are not practicing for this hospital. You are an entirely private nutritionist that I hire for my private surgical practice. And I cover your insurance entirely. If anything goes wrong, you keep your license. It's not your fault. Would you be willing to formulate such a TPM bag for me? Basically, I exonerated her from any responsibility, just saying, do you think this is something logical to try? She still says, yes, I see the logical point, but I just don't feel comfortable trying it. Somehow you can see there's this kind of cognitive barrier there. Like she's absolutely because I work with her on other patients as well. By the way, she intellectually discussed different patients' case with me. I know she's not dogmatic or just not receptive to new ideas or not able to grasp the concept. But somehow I just think we're doing those patients a disservice by chasing them with insulin. Like the endocrinology consult is placed every day. We're calling them day in, day out, long-term, like fast-acting, slow-acting. And we're still putting dextrose into the TPM bag. And I just want people to know, probably people without this knowledge wouldn't even advocate for themselves or for their loved ones to say, hey, look at his TPM bag originally had over 200 grams of dextrose. I was the first one to say, okay, let's reduce it to the minimum you must be putting in.
Yeah, that is a very common scenario. Whipples are not that common. They're more common than they used to be. But more importantly, most people in the hospital for any reason they're getting an IV with dextrose in it for the most part. Some people use some version of normal saline, but it's usually lactated ringers or some kind of D5 or whatever. And so you're constantly going to be spiking people's blood glucose and then chasing it with an insulin sliding scale. And that's all day long, every day. And so it's a significant problem, obviously. And I think that the dietitians that formulate the TPM or other diets, they feel that they have to toe the line or else, and they're not allowed to ask questions. And it's kind of medicine in a nutshell in many ways. It's very frustrating to do that stuff. And so you put yourself at risk by doing so in many cases, because if you deviate from the standard of care and there's a complication, then you're set up for litigation. And so there's significant disincentives to do that stuff. I want to go back because, again, it's interesting because you just did your surgical clerkship and it's an interesting time. You see a lot of stuff. For the majority of this, because you said you want to focus on neuropsychiatry and how nutrition plays a role in that. And so what do you see you looking into? Are you going to be primarily still in the lab doing research, or are you going to be having an active clinical role? Are you going to be doing a little of both? Where do you see you're going to be going once you finish all your training?
Yeah, so for us who have dual degree or who's on a dual degree MD PhD path, we usually pursue what we call a research track residency. So you do become a board certified neurologist, psychiatrist. So you can choose one, or you can be dual boarded neurology and psychiatry. And then you go through the fellowship research phase where your goal is to establish your own research lab. So for people who succeeded in this training path, your ideal career path would be maintain clinical practice and maintain your own research lab. And then how much time you allocated to each depends on your funding status. you have ample funding from both private and NIH or government fundings, you can cut. Some very successful MD PhDs don't even need to see patients because you make money for an academic institute by either contributing your research funding or you go see patients. So usually as a starting physician scientist, we see patients about half a day, or you maintain half a day or a day clinic every week. And then you can gradually cut back on your clinical service. But some people do not cut back because they want to maintain this clinical connection with their patients. They feel it's an important component of their career. Yeah. One of the most successful MD PhDs in Stanford who still maintain his specialty clinic of treatment-resistant depression. Yeah, he's one of the successful neuroscientists in just systems neuroscience.
Okay. You've got to finish the residency, which is at typically a psychiatry residency, a neurology residency, I believe is 3 years, maybe 4 years. What is the length of time?
Interestingly, internal medicine and neurology, you think internal medicine is mucking around in people's hearts and lungs, right? Hearts and lungs, all sorts of organs. And neurology, you're mucking around in people's brain and spinal cord. Those are 3 years. But psychiatry residency is 4 years because our drugs and our treatment, like those ECT, electroconvulsive therapy, are so potent. That's why psychiatrists, their license means a lot because they get access to controlled substances. Just as a side note, you guys probably know a lot of the antipsychotics are metabolically very hostile to people. Olanzapine, people go up to 60 pounds weight gain within the first year getting onto olanzapine. And now there's a school of practice. Actually, it's not only within a small circle. We don't call it standard practice, but whoever can get onto olanzapine, they get onto Ozempic right away as well. So we're trying to pair them up. You basically use a drug to treat the problem caused by another drug.
Yeah, maybe they'll make a combination drug where they just shoot them all in the same syringe or something like that.
Which is still, I'd rather my patient be on both and not gaining 60 pounds and become all dyslipidemic and become insulin resistant. But I just felt that maybe before that person get onto olanzapine, what's the root cause of this person become so psychotic and cannot be controlled by even milder antipsychotic medication?
In your view, what do you think is a root cause of some of these psychiatric conditions?
I think one component is certainly neuroinflammation, which we have very poor tools to quantify at this moment, I must admit. I think this phenomenon exists and it alters the neuronal firing pattern, both globally and in local neural circuit. But I don't think you can measure neuroinflammation by say, what's your CRP score, or that's just bogus. That plays a role. And I think secondly is the aberrantly repeated activation of certain neural pathways, either by us mismanaging stress or not giving people the correct CBT or DBT in a timely manner or in a manner that's not suitable for certain people's already ingrained neural circuit firing pattern. So if someone have certain, say if I can do talk therapy with this person and then monitor their neural circuit firing pattern all the time, certain firing pattern, and you try to forcefully correct it in a way that's going to activate aberrant pathways, I do think that can make someone psychotic.
Okay. So neuroinflammation, some aberrant repeated pathways. I would imagine there are some nutritional components, deficiencies, and things like that would probably contribute as well.
Yes, certainly. Say, for example, if you just cannot make certain neurotransmitters, then, the neuron wants to fire, then what does it discharge? It has to discharge something that in its vesicle. Now the vesicle doesn't have the correct amount of one neurotransmitter. It's just going to discharge whatever it has there. And then whatever it has there goes out, may not be activating the correct receptor or may not be going into the correct neural circuit.
So I've been seeing thousands and thousands of people on a carnivore diet now, and many of them notice improvements in mental health conditions. Many of them lose weight. They note better satiety. Why do you think we're seeing that?
I personally experienced that too. And that's why I eat a carnivore diet. I eat actually just very interestingly, I go to my local butcher shop to buy my beef fats almost every other day or every 3 days. I walked into my local butcher shop. Yesterday, one lady was buying, I think she was buying the porterhouse, very beautiful cuts, I must admit, for her family's July 4th grilling. And then the butcher was trimming off all the fats. And then she doesn't want all the fats, and I want all of them. And then if you look at the two people, like two of us, I'm not discriminating. She's obviously not very fit, just a general kind of overweight to obese body habitus average person. And I weigh about like 80 to 85 pounds because I'm in a cutting phase, and I do want to cut while see how much I can maintain musculature. So I'm in that phase. I was wearing a 20 pounds army weighted vest with another 10 pounds of ankle weights that I carry on back sack. So I do weighted walking, and I want all the fats. And I think she paid $104 for all her beautiful porterhouse. The butcher charged me nothing for all the fats. So I do personally experience the benefits, certainly in my own kind of recovery. I do think the fat molecule, the cholesterol, are a lot of the building blocks. First, for certain hormonal neurotransmitters, I think previously we put too much emphasis on peptide-based neurotransmitters that are protein-based. Now I think we are recognize more and more of the fat-based neurotransmitters that's made of either hormones or hormone kind of, basically fats is the building block, or small kind of lipid molecules are the building block. So we're increasingly recognize their role. I think they were ignored previously because the quantity is so small. We can't even, if you single cell RNA sequencing the transcripts of genes that makes them, the amount is so small that they just fall off the curve. It's not detectable. So you don't think the brain is even making it at all. But as we were increasing the sensitivity, the way we can pick up low abundance transcript with single cell RNA sequencing, more and more we're picking those up. And then actually we're actively doing perturbation experimenting, using them, those microdialyzing in a small amount. And we do see very legitimate biological effect. So that's one of the reasons. And secondarily, I do think just in terms of overall, I can't say for sure, but I think if your overall, I can't describe, I don't have enough kind of clinical expertise on myself. I haven't neuroimaged myself for frequently enough. I think if you're overall mood stabilized enough, which I do feel carnivore diet contributes greatly in my own case, you tend to be more cognitively agile and stable in doing higher level work. Because you have to have, you can't be jittery all the time to say, I'm going to go code something up. That's highly cognitively demanding.
Yeah, fair enough. And a lot of people will mention, famously, Joe Rogan came out recently, said he just feels like his brain works a lot better when he's on carnivore. He doesn't have a loss for words. He's able to speak and communicate more fluidly. And I think a lot of people notice that. Because I think this topic is really interesting, because We have so many people, as you mentioned, the normal body habits these days is pretty much certainly overweight and in many cases leaning towards obese. And that's not going away. It's getting worse and worse as time goes by. And some people think the answer is just put everybody on a GLP-1 receptor agonist. And I'm sure they're going to make hundreds of billions of dollars on that particular drug. But is that going to solve the obesity crisis, do you think? Do you think that's still basically a symptomatic Band-Aid in your mind?
I'm a little I do have a personal belief, like I tend to maintain a Catholic faith just to myself. I don't advocate it in the public. I don't try to sway anybody. Interestingly, someone reported me on the wards for praying with patient. So a patient, before she went into surgery, she asked whether I can pray with her. She's Catholic. And she's Spanish speaking. She's one of the, if you want to advocate for minority groups, she should be one who you advocate for. And actually, I had to communicate her with a translator or interpreter. And someone reported me for agreeing to pray with her before she went into surgery. It's a different topic. So I do believe a bit more above the materialistic aspect of life. And I do agree the body habit sometimes in the surgical, on the OR, they just, whenever we need to move a patient, they just kick me to the curbside. They said, you are not equipped to do, just don't touch the patient. Let us do all those transfer maneuvers, all those boards and the sheets we do to pull patients around. I think acutely, you can decrease people's body weight for sure. First, those drugs are new. And I do not have enough confidence to say, we do see certain cancers, rare cancers with animal study. I cannot promise they're not going to be prevalent in human population. The other part is the disproportional loss of lean body weight compared to fat with on Ozempic compared to a gradual weight loss. But more profoundly, I don't think you're going to produce a happier, a more content population by putting everybody on Ozempic, even if we produce a physically leaner population.
I guess the interesting part of that was they reported you for praying with a patient. Are you not supposed to pray with people anymore? Is that considered a problem?
I think the person who reported me was thinking that I was outwardly demonstrating the preference or my personal choice of one faith over the other in front of patients, and that can potentially be problematic. But interestingly, the attending on service that week, she's a hardcore Catholic. She even says, bless your heart, or something very cutely Catholic in front of the entire team and in front of patients. So I didn't get into any trouble. She said, that's bogus. Just don't pay attention to that. But you can see the person probably, I don't know, maybe the person who reported me want to protect patients of other faiths as well. I didn't take it too hostilely, but I thought it was interesting.
Yeah, it's a little bizarre that someone reports you for praying. Anyway, I guess times have changed a lot since when I went through. That was not considered weird at all. You often would have pastors and preachers and priests come in and pray with patients before things. It was considered normal. I think the patient wants it in a lot of cases. They're comforted by that. And as you mentioned, I'm sure she was Catholic herself. So you said you're preparing for your board examinations, which good luck with that. Those are a lot of studying that goes into that. I remember studying 100 hours a week for months and months or something like that. I can't remember when I took my boards, but it seemed like it was a lot of studying to get that done. And then, so that should be fun for you. I'm sure you'll do fine.
And Shawn, to be honest with you, I was in contact with other members of the Revero and Carnivore Diet team just to do some back-end work for the AI-powered platform that you guys are developing. Although I must admit, I haven't been able to be very substantially devoted to the work. But we were talking about, say, folks, at one period, I was reviewing lists of conditions that we may want to include, or the list of the type of studies we may want to include in the study, and what type of clinical study we should be pursuing to demonstrate efficacy, etc. I do look, once I pass this really busy phase, I think into the fall, I do want to kind of just starting by even volunteer my time to be more involved in the development of the platform that you and others are currently developing, because it's very new, and I do want to see how combining technology and the human intervention, like human interpretation of the data, can take us to in terms of a new chapter of patient autonomy-driven healthcare.
Thank you for that. And we look forward to having you as a valuable member. We are, like I said, we are just in the finishing phases to get our launch going. And then I'm sure we'll be iterating and reiterating for many years to come as we learn more about this stuff. You'd mentioned the Whipple procedure and cholecystokinin, or CCK, how its impact on the gallbladder causing
the gut motility.
Yeah, so it has a number of roles in there, but it was initially described because it caused the gallbladder to contract, I believe. What do you see as, I'm just interested in this brain pathway, because you mentioned the hypothalamus, and I can't remember the pathway, you said something like PONC or something like that. But what, if we could say, these are the important things that impact our tendency to overeat. You mentioned a hedonistic pathway and a homeostatic pathway. What do you think the big drivers are? What are the problem areas? Some people say you just need to cut out sugar, and some people say it's you need to cut out these oils, and some people say it's processed food. What are your thoughts?
Actually, I think for people who are especially actively seeking help in this realm, actually, I do think there are people who, at least let me put it this way. I think if I am someone who's seeking help in binge eating, overeating tendency, I would want someone who have credentials in psychopharmacology, to not simply like online trained certified coach. I trained with this online personality for 4 months. And then now I'm a coach. I can cure your binge eating tendency. The reason is that I can give you the example. In binge eating, the drug we use to effectively actually control binge eating can also treat what a psychiatric diagnosis that we call hyperorality. So hyperorality includes not only binge eating, but also pica. And pica can be obsessively chewing anything, ranging from more benign things like ice. That's the most common pica. People obsessively chew ice cubes. It can be kids chewing paper. It can be kids biting paints off the wall. It can be people chewing true needles and getting themselves all bloody in the mouth. They can't control the urge. That's how bad, how powerful this neural circuit is. So the same drug that can target the neural pathway of binge eating also treat hyperorality. And then do you know what this drug that treats hyperorality also treat? It also treats hypersexuality. So we actually interestingly have elderly men being transported from nursing facility into our hospital for no reason other than they are just grabbing female nurses left and right, out of control. Nobody can control them. And then the nursing facility does not have enough male staff to staff around him 24/7. So this is the hypersexuality. As you can see, the pathway overlapping. So you truly have to understand what pharmacological agent you're going to use, or if you are not using a pharmacological agent, what psychopharmacology pathway you're going to be targeting in this specific patient case. And then interestingly, conversely, if someone is suffering, we know if someone is suffering anorexia, you try to activate this true orofacial pathway to get them to eat more. Guess what? It doesn't work. And we still do not know why. So the reverse of it, you think you're going to elicit this feeding drive by reverse engineer this pathway. It doesn't work. So I would say, given that they are good doctors, we have this training. There are fellowships of psychopharmacology out there. For example, the leading psychiatrist who directs our consultation liaison service in our teaching hospital, she did her psychopharmacology fellowship at Sloan Kettering. Because those people are available out there, if you truly want to get a good help, and they don't charge exuberant amount. So I think that's the right people to seek help to. Because they can, based on your symptoms, how your binge eating manifests, what other symptoms you are experiencing, they can delve into the correct pathway or the correct possible assisting medication or supplements even to use. Not go for someone who just trained with the online personality and then get the self-claimed coach.
Okay. Yeah. I have to go, unfortunately. Thank you so much for doing this. Congrats on finishing the lion's share of your medical training, except for the residency part coming up. So it's another bit of fun, but we'll get another update down the road, I'm sure. Thanks so much. Rest of you folks, we'll see you guys back tomorrow, the 4th of July. We actually have 3 interviews to do. So anyway, thank you guys so much. I appreciate it. Thank you. Thanks.
And just last words, if anybody wants to give me any feedback, please feel free. I welcome any feedback, and I want to know in the future, because I do want to go, but I used to host the community meeting on a platform. I got busy. I do want to restart the meeting, and I want to know if I do restart the meeting, what would be interesting to our audience. Yeah. Okay. So I welcome any feedback.
Perfect. Thank you. Thanks, guys. I got to go. Bye-bye, everybody. Take care.